Hello and welcome to Connectome of the Week. My name is Dr. Jonathan Sherman and I am the Director of Surgical Neuro-Oncology for the Eastern Campus of West Virginia University's Rockefeller Neuroscience Institute. Today we're going to talk about a patient that we recently treated. This is a young lady that came to the hospital with acute left leg weakness. She actually had zero strength in her leg by the time she got to the hospital, and we had imaging which showed a mass in her primary motor strip. And so here is a coronal view, and this is using the corticospinal fibers, and what we see here is a mass. It's about 3 centimeters. On this coronal view we can see that. We have the opposite side to show what the normal fibers should look like, and so we can see those corticospinal fibers going up into the leg area. And then on the right side, we see that those fibers are disrupted. Our normal blue colorated fibers are actually now a variety of different colors, including green and red, based on their color change, based on directional change. And so essentially these fibers were non-functional. And we knew that based on the fact that she could not move her leg at all. And so here, we actually can once again see the normal side of the fibers on this axial view. And then when we go slowly through, we can see where the fibers are coming up. And then we have the normal blue fibers on the normal left side. And on the right side, we have all these color changes between the green and the red, which is indicating that these fibers have been disrupted and then they're not functional. And so that helped us figure out how we were going to get in there to remove this mass. We have these other fibers which are in the hand area. They're normal. She had normal hand and arm strength. And we knew that if we avoided those fibers and went right to the surface, this thing, of course, like most tumors, doesn't come right to the surface. There was going to be tissue. But we knew that those planes in that tissue would probably be non-functional. And we did a sleep motor mapping during our surgery. And that sleep motor mapping allowed us to stimulate the brain and isolate where the hand area was. And in addition, we isolated where there was non-functional tissue, because not only was she not moving, but the diffuser tensor imaging, the actual corticospinal fibers, where it was able to show us, even on the actual intraoperative imaging. So when we, take our three-dimensional view, we can actually see, where the mass is. And once again, as we zoom in, we can see that there's virtually no fibers coming to the surface of the brain here compared to the normal side. And so that gave us direct access. And so now what we're going to do is cut over to some images we actually used in the operating room, where we linked the Quicktome platform to our stealth neuronavigation, as well as to our virtual reality platform with surgical theater. We are in the operating room where we perform surgery here at the WVU Eastern Campus. Behind me is the patient's bed that the patient would have been sitting on the day of surgery. On my left is our stealth neuronavigation system, where the patient's imaging is already integrated with the Quicktome platform. On my right is our surgical theater virtual reality system, where we have a 360-degree reconstructive image of the patient. And so first things first, with the patient here, we actually have a reconstruction of their face. And so there are markers on the head. We can use facial reconstruction, where it's like GPS for the head. And we can also use these markers as point of reference so we can know where we are. And so we have integrated the tumor, which is here and here, with the corticospinal fibers, the fibers that we want to protect, and also we want to find our way in. And so one of the things we can see is that as we come up to the surface, the fibers, just like on the Quicktome platform on my computer, were all abnormal in the way that they were around the mass. They're still abnormal here labeled in green. As we get to the surface, we see that there's a vein that we want to protect. So that helps us out. So we know we're going to be a little bit lateral to that vein. And when we're a little bit lateral to that vein, we see no fibers. And so those fibers give us, without being there, give us direct access to the tumor without causing any deficits. And then on top of that, we can go down a little bit and we can see the fibers where the hand area is, and when we were in surgery that actually mapped out. Our reconstructive image is very helpful. On the left here we can see the patient's head, so we can map out exactly the direction we want to be. Now at this point we don't have the corticospinal fibers on our reconstructive image. We are working with both companies to actually bring that in, so that's a work in progress where all of these fibers will be on the reconstructive image. For the time being, we know based on where they are on our two-dimensional view that this is our hand area here and the tumor is here, and we see once again those veins, so we know that the silent area, which shows up on our 2D reconstruction, on our 3D, we know that that's our silent area, so we know exactly what it's going to look like when we get into there in surgery. And then when we do the surgery, and we actually did the surgery last week, it actually let us exactly what we thought we were going to see. So our pre-planning in our head was actually a pre-planning on 2D and 3D constructive images that bore out in the surgery, and the patient had a good outcome. So now that we've removed the tumor and we have our post-operative MRI, we can take the pre-operative imaging and compare it to the post-operative imaging to show what's happened with our corticospinal fibers. So here's our pre-operative imaging, and now we have another Quicktome opened, and now we can see our post-operative imaging. So here is our fibers on the normal side, and as we go through that, we can actually see where the resection is, and we can see the fiber tracts are still going up to the surface. They're just not going right to where the lesion was. And she actually started moving her leg post-operatively. So by the time she left the hospital with having zero strength in her entire left leg, she probably, what we rated it as like a 4-. She actually had ankle and foot and dorsiflexion strength where she could move her ankle and not trip. And so she didn't even have to go home with a foot orthotic that would keep her from tripping. So that was a nice outcome. We certainly like that. And we can validate why that is, because we can see where these fibers come to the brain surface. And what they've essentially been pushed to is to the side, away from the medial aspect where they would normally go, because those were disrupted, and the fibers that are of value for the leg function are now more lateral. Thanks for joining us on this episode of Connectome of the Week.